Thank you for joining me today. In this video, I want to go over a story of a provider who want to treat a patient with hypertension, and the decision is he has to make to be effective. So here is the story of the provider. Managing what the numbers does not show. That he's talking about the blood pressure. The patient's blood pressure is still elevated. You have seen them multiple times now. They have been taking their medication. Bill Barrel confirms that. Their story matches their real history. 3 agents are already on the board, include diuretics, each at the appropriate doses. Lifestyle changes were discussed months ago. Revisit last visit and the partially implemented. Yet today the reading is unchanged, so the blood pressure didn't change. Before making any adjustment, you pause, not at the medication list, but at the measurement itself. The cuff size is correct. The patient rests, feet flat, back supported, arm at the heart level. You repeat the reading, slightly lower, but still above the goal. Now the broader decision begins. You consider the physiology. Is this primarily driven by the cardiac output, peripheral resistance, or both? Could there be an underlying secondary cause that does not yet been uncovered? Resistant hypertension is no longer defined in textbooks. It is primarily for deeper evaluation. Renal diseases, endocrine causes, medication interaction, lifestyle factors all move higher on your differentiation diagnosis. You revisit the non-pharmacology strategy, knowing that the lifestyle change can refile the effect of adding other drugs, sodium intake, weight, physical activity, alcohol use. These conventional are not always easy, but they are necessary. At the same time, you know these patient comorbidities place them at a higher cardiovascular risk, making the timely blood pressure control essential. When you do adjust the therapy, the choice is deliberate. Evidence guide your decision, but the decision is an individual accounting for their comorbidity conditions. Consent medication is the cost, what this patient can realistically sustain. The medication itself matters, but what matters more is whether the plan actually helps the patient to reach their goal of blood pressure control safely. As this visit ends, you schedule follow-up sooner than usual, not because the protocol not because of the protocol alone, but because this patient risks complexity and current control demand closer monitor. So the patient demands close control monitoring. Hypertension management once again profiles to be less about treatment numbers, and more about managing a long-term risks. Reflection question is: thinking about a patient with hypertension, those blood pressure remains above the goal desired therapy. How did measurement technique, lifestyle factors, comorbidity, or possible secondary causes influence your next step decisions? How may applying these key concepts nearly change your management approach in the future cases? Diagnosis is not the challenge. The blood pressure has been above on 3 separate visits. Choosing the right medication. What makes more time is decision how to treat the hypertension. You review the chart before walking into the patient room. Patient is a newly diagnosed but already high risk. Long-standing diabetic. They have a long-standing diabetic, early chronic kidney disease, family history of cardiovascular diseases. Their blood pressure is not severe, but it is persistent. Lifestyle counseling has begun. Dietary changes, physical activity, sodium awareness, but these interventions take time to translate into the measurable improvement. Now comes the medication decisions. Several options will lower blood pressure. On paper, many look interchangeable, but you do not start with the medication. You start with the patient. The kidney function matters here. So does the presence of diabetic. So does the cost, because they have already mentioned strengths prescription at the end of the month. You check their current medications, mindful of the interaction and comorbidity side effects. that could quietly undermine the adhesiveness. You consider the evidence. Certain medication classes often benefit that extended beyond the blood pressure reduction alone. Renal protection, cardiac, vascular risk reduction, that the shift is the decision. Those shift to your decisions. The best medication is not the one that lowers the blood pressure number faster, but the one that aligns with this patient's comorbidity long-term risk profile. You also think about the practicality. Once a day dosing will help. Medication with favorable side effect profile will make the patient take their medication more likely. You avoid adding complexity where it is not necessary, knowing that controlling blood pressure is usually more important than which specific agent you choose. Before finalizing your plan, you talk it through with the patient. Your explanation not just what you are prescribing, but why. You clarify expectations, side effects to watch for, when to follow up. The prescription is written, but the decision extends beyond the orders. It includes monitoring, reassessment, and understanding that this therapy may evolve. As you move on to the next patient, you are reminded that medication selection is rarely about finding the perfect medication. It is about making the most thoughtful choices possible for the person in front of you today, while leaving the room to adapt it tomorrow. Reflection questions. Thinking about the recent time you selected any antihypertensive or other chronic disease medications. Which patient-specific factors most influence your decision? How did you balance evidence-based benefits with the practicality and long-term adhesiveness? When the drug is not enough, the blood pressure has not improved since the last visit, but not enough. So blood pressure has improved the last visit, but it's not enough. At the last visit, you start with monotherapy. The patient tolerated well. Follow the recommendations. So the patient tolerate the medication well, they follow the recommendations, They made small changes, but gradual life changes that are gradually life changes. Today, readings still better than baseline. Today, readings better than baseline is still above the goal. Not dangerously. Not dangerously so, but persistently. You know from the experience and evidence that waiting too long won't help. This is the moment where combination therapy becomes part of the conversation. You look beyond the numbers and think in a mechanism. One agent is already addressed part of the problem, but hypertension rarely travels a single pathway. Cardiac output, peripheral resistance, volume status, each play a role. Adding a second medication that works through a complementary makes more sense than pushing the first drug to its self-limit and inviting a side effects. Because if you increase the dosage, you are pushing the first medication to its limit, and that increases the risks. So you consider options carefully. The second medication could enhance efficiency without combining risk. Lower dosage of a two drugs often achieve better blood control with a few side effects than higher doses of one medication. You pay attention to comorbidity, knowing that certain comorbidity often add protection. Knowing that certain combination of a medication adds protection to kidney, cardiac, metabolic, while others may introduce avoidable complications. Practically matters too. Once a day dosing, fix a dose combinations affordability. These details influence patients taking their medication far more than pharmacology alone. You choose the regimen that the patient can realistically sustain. Not just today, but months from now. When you explain the plan, you are deliberately with your words. You do not frame the second medication as a failure of the first one or of the patient. Instead, you normalize the approach. Most patients requires more than one medication to reach target blood pressure safely. Combination therapy is not escalation. It is optimizing. You schedule a follow-up with intention, knowing that the combination therapy demands monitoring. Electrolytes, you want to monitor the electrolytes, renal function, blood pressure trending, tolerance, all need a reassessment. Hypertension management remains alertive, not static. As the visit ends, you are reminded that the combination therapy is not about adding more. It is about achieving a balance. Balancing efficiency with safety, guidelines with individual, long-term outcomes with everyday reality. So the reflection question is, think about a patient for whom you initially consider a combination therapy. How did underlying physiology, comorbidity, practical influence your decision and choosing the right medication? How did you frame the decision to support the patient understand and take their medication? Seeing beyond the numbers encounter. Thank you for joining me. I am going to make more video like this, so if you like it, please subscribe and let me know. Thank you.